Good evening, everyone. So this week we are continuing our lecture series on STI topics. Now we have discussed chancroid and donavanosis in the last 2 weeks, and this week we'll focus more on lymphogranuloma venereum. Now this disease is very important to understand because the we might be knowing that LGV is divided into three stages. You have first, second, and third, and then you have all sorts of disfiguring complications that arise in the later stages. So it becomes very imperative to diagnose the disease early on so that you can treat and prevent those complications from occurring. Otherwise, the treatment of those complications are not that easy. They are very disfiguring. They will have a significant impact on the patient's life. So it becomes very important as a venereologist for us to recognize this disease quite early on and make sure that we do not leave any patient suffering from LGV as untreated. Now, like every other genital ulcerative diseases, the prevalence is decreasing, of course, with good amount of antibiotics and good patient care, and a lot of patients are coming to the STI clinics and getting treatment on time. But with the advent of HIV epidemic and advent of antibiotic resistances in LGV, we are having issues with the recurrence of genital ulcers, and we must know a bit about LGV as a clinician, and also it becomes a very important short note in your exams paper number 3 also. Okay, so without further ado, we'll start a discussion on LGV. Okay, lymphogranuloma venereum. Now, one thing you have to understand is just look at the name. It involves lymph nodes by a granulomatous inflammation, and it's a venereal disease. Clear? So just look at the name and you will understand what actually happens. If I want to expand this pathophysiology of LGV, the initial you could say the initial manifestation is a genital ulcer which is superficial and it might resolve spontaneously. That is why more often than not the first stage might be missed. Okay, so what happens is that this kind of inflammation from the eroded mucosa which has caused the ulceration, the organism travels and blocks the lymphatics and lymph nodes which are draining from the affected site. And when those lymph nodes get infected by the organism, the lymphadenopathy occurs. They increase in size, and when the inflammation is prolonged and crosses a certain threshold, the lymph nodes become fibrosed. Additionally to that, the infection of the surrounding tissues increases the inflammation and subsequent fibrosis of the surrounding areas. And when the fibrosis is significant, it might lead to significant sclerosis and stenosis, and also formation of multiple strictures which might involve urethra, vagina, you could say rectal stenosis and all that. So that is why the complications of LGV is significantly important for us to understand, and that is why we need to know about this disease. However, it may be nowadays rarer, but we must know about it so that we can diagnose it properly and on time. So let's start with the discussion. LGV primarily involves the lymphatics, we know about from the name, and the causative organism is Chlamydia trachomatis Biovars L123. That is L1, L2, L3. Okay. Now, Chlamydia trachomatis usually cause another STI known as chlamydiasis or the chlamydial discharge. That's a part of genital dischargeal diseases. Okay. But the Biovars, okay, we will not go into depth what is Biovars, what is Serovars. If you want a clarification, just write in the comments and I'll mention that. Otherwise, Biovars L1, L2 and L3 are the Biovars of Chlamydia trachomatis that are responsible for causing LGV in humans. Okay. But there have been multiple names over the years for LGV. It has started with, I think the first name was Climatic bubo, at least in India. So this was, I think, first name in India. Other names are tropical bubo, Porodonitis inguinalis, Lymphopathia venereum. I have not had good references with 4th, 5th and 6th disease, and they can be easily confused with the viral exanthems, so I will not mention those. So important name would be a climatic bubo because that was the first name given to the disease, which was later characterized as LGV. Other important name is Durant-Nicholas-Favre disease because this has been asked in various quizzes in Viva also, and these three are very important scientists in the history of LGV, so that becomes an important name. So let's understand the history of LGV first. It was initially described in 1833 by Wallace, and by Nelaton and L. Hardy. What they did was they classified it as an STI, that means sexually transmitted infections. So the infection or the ulcer was described first by Wallace, and subsequently, after around 60 days, 60 years or something, Nelaton and L. Hardy, they classified this disease as an STI. Now, Caddy was responsible for naming this disease as climatic bubo. So I said that climatic bubo is the for one of the first names for LGV, at least in India. So in India in 1902, Caddy termed this disease as climatic bubo. It was Durant, Nicholas, and Favre which in 1913 gave the name Lymphogranuloma Venereum or LGV, and that is the name that has stuck, and that is how we know this disease now. Fry is responsible for intradermal test, development of an intradermal test to diagnose. However, this test is not used now. It's an obsolete test. And if you remember this name Fry is supposed to create a lot of intradermal tests for various disorders. So subsequently, the intradermal test for LGV was also formulated in 1925, but it's an obsolete test now. It's not used. Favre, the same Favre here. Favre was responsible for isolating the organisms, and the histopathology was described by Sheldon Heyman in 1947, year of our independence, and they described stellate abscesses. So you have this kind of cross-sectional star-shaped abscess which are known as stellate abscess, and also if it has multiple arms, then it becomes a stellate. If only 3 arms are present, then it becomes a triangular abscess. So all of these descriptions were given by Sheldon and Heyman. So as I've said before, like all genital ulcer diseases, the prevalence of LGV is decreasing subsequently. And because of the rise in HIV epidemic and resultant immunosuppression, the incidence is showing a spike of increase. A spike in the prevalence. Now, another spike which we should mention is a spike in MSM population. Okay, so in MSM population, it has been found that LGV is quite endemic because of the resultant sexual practices. Apart from that, there are centers for LGV mainly in Europe, tropical parts of Africa, Asia, South and North America, and Oceania, which includes Indonesia and parts of Australia. But the most important population for LGV is MSM. So we need to make sure that we keep that in mind. Okay. Now, one of the important thing is Amsterdam variant. Now, this is a very important topic in LGV. It's a very important. I think we at least I have got one short note during my residency days on short note on Amsterdam variant. Now, Chlamydia trachomatis Biovar L2B is known as Amsterdam variant. Okay, so as we know that we have L1, L2, L3 causing chlamydia, causing LGV, and subsequent sub-biovar of L2 is L2B, which is known as Amsterdam variant because it was isolated in Amsterdam. So in Amsterdam, there was a sudden spike in the cases of LGV, and this spike was seen majorly in MSM population. And that is why when the organism was isolated and labeled as L2B variant, the name given to that variant is Amsterdam variant. So this name is important. Sometimes they ask in Viva, what do we mean by Amsterdam variant? And this population, MSM population, they were also subsequently, affected by retropositive virus or HIV, and they showed high risk behavior. So, in patients who have a co-infection with HIV or those who indulge in high risk behaviors, the Amsterdam variant has been found to be isolated from those ulcerative disorders. Now, you must understand that Amsterdam variant is not the most common variant causing LGV. It's just that a specific recent variant. And when I say recent, if I remember correctly, it's about 2005 or 2007 roundabouts, where the Amsterdam variant was isolated. Okay. Apart from that, if we are not talking about MSM population, in heterosexual population, the L2 biovar or the complete L2 biovar is responsible, and the pockets are seen in Spain and Portugal. Majorly, the ages which are involved is 20 to 30 years, again the reproductive age group. So these are the reproductive age group. So where we have significant population getting affected by LGV. First stage is the most common stage that we see in males. See, because what exactly is first stage? First stage is genital ulceration. Okay, so you will have a somewhat of a jagged ulcer, maybe at the corona, or near the glands or top of the glands, or the glandular mucosa. And since this site is very much visible, it causes concern in the patient. So when that concern is there, the patient will come to the STI clinic and take help. That is why the most common stage in males, which is recognized in the clinics, is the primary stage. Now, what happens in females is that the ulcer might be hidden, or it might just be involving the cervix, and because of that, the ulcer is not seen. The ulcer heals spontaneously, and this leads to the movement of the disease from first stage to second and third, and the most common stage that females will come to us will be in the deformity stage or the third stage. That is why the first stage becomes very common in males, while the third stage becomes common in females, because the first stage is often missed. It can affect the newborns via the infected vaginal canal. Transplacental migration has not been reported, but if a neonate is delivered to a mother who is infected with chlamydia, that can of course happen. We'll discuss the treatment of neonatal chlamydia when we are discussing chlamydial discharges. Okay. So let us first understand what exactly are the Biovars distribution in chlamydia. So it starts from A. Biovars starts from A to K. Okay, A to K. A, B, BAC causes endemic trachoma. So by trachoma means roughness, and usually trachomatis you will see in eyes. Okay, so it usually infects the eyelashes, eyelids, and because of that there are raised bumps, and because of these bumps in the conjunctiva, you have the roughness of conjunctiva, and that is why it is known as endemic trachoma. Clear? So the Biovars A, B, BAC are responsible for endemic trachoma, and it is mostly it is concerning to the ophthalmologist, not to us. We are concerned with the L variant majorly. Now the L variant causes LGV, where the OMCB gene binds the heparin sulfate, and that is responsible for infectivity. Now this is one of the reasons. Okay, there are multiple reasons and multiple genes which are responsible for the infectivity of the organism, but the OMCB gene has been reported, and it acts via binding the heparin sulfate molecule. So this I've just included because this could be a good quiz question or a good Viva question, that what gene is responsible for infectivity. The books mention OMCB. Now, what exactly happens? The organism enters the mucosa, infects the mucosa, causes an ulcer. After that, from the ulcer, from the eroded mucosa, it goes inside macrophages. And after going inside macrophages, it starts to multiply a lot. When it multiplies, it increases in population. It infects the draining lymphatics. And from the lymphatics, it goes to lymph nodes. And from lymph nodes, it causes lymphadenopathy, which will subsequently become inflamed. And there will be significant fibrosis. So that's how LGV moves. It moves from mucosa to macrophage to lymphatics to lymph node to lymphadenopathy to inflammation to fibrosis. This is the a short recap of LGV infection. So if you understand this process, you can easily write pages and pages on LGV. So L variant or L Biovars is divided into three parts: L1, L2, L3. L1 is responsible for causing proctitis or the inflammation of rectal mucosa in MSM population. L2 is the most common variant causing causing LGV. So remember, in prior slides we had discussed that the L2 variant is responsible for the heterosexual transmission of LGV, and it is the most common variant which is causing LGV. L2 is divided into L2B and L2C. L2B is known as the Amsterdam variant, a very important variant to study, which is responsible for MSM epidemic, but the clinical severity is less as compared to the normal heterosexual LGV. L2C is responsible for severe proctitis and a severe clinical course. So L2B, which is the Amsterdam variant, is less clinically severe and is responsible for MSM epidemic, while L2C causes severe proctitis and clinical course. L3. Okay. Now after that you have D to K variants, which are for ocular-genital infections. We'll discuss them later. But LGV is caused by the L biovar of Chlamydia trachomatis, divided into three parts: L1 to 3. L2 is most common for heterosexual transmission, and L1 in MSM proctitis. Okay. So we are clear on biovars. Let's move forward. So we have discussed the history of LGV. We have discussed biovars. What do we actually mean by biovars? We'll discuss a bit about the agent. Okay. So LGV is caused by Chlamydia trachomatis. We know that it's a natural human parasite. It's an intracellular parasite. So what happens is that this is the cell, or rather, this is the cell, somewhat of a columnar epithelium. Okay. And what happens is that the elementary bodies of chlamydia will enter the cell, and inside the cell they will multiply and become numerous in number, and subsequently what happens is that the cell actually ruptures, and when the cell ruptures, all of these elementary bodies are released. Okay, and they will infect other cells subsequently. So it's a natural human parasite. It can survive only in humans. There are no other non-human reservoirs. It's an obligate anaerobe. Of course, if you live inside a cell, you're anaerobe. It's filterable organism. That means it is so small. The size is very small, and it has a cell wall. It is responsible for causing pneumonia, psittacosis, which is birds transmitted disease, trachoma of the eyes, and LGV in humans. It reproduces by binary fission. So when I say that these are going to divide to become numerous, it's because of it's via binary fission. They do not produce ATP. That is why they are obligate intracellular organism. So what happens is that they hijack the machinery of the cell, and they make use of the ATPs that the cell is producing for itself, because they themselves cannot produce ATP for their energy transactions. They have both genetic materials, DNA and RNA, and there are three biovars, but we have discussed that in detail. So just remember a few important points. It's a natural human parasite. It's obligately anaerobic and intracellular in appearance. And they reproduce by binary fission without forming their own ATPs. Here we can see a cell which is infected by the elementary bodies of chlamydia. Okay, so these are all elementary bodies sitting here. This looks like, these are all, it's a cell which is filled with, elementary bodies. And subsequently, the cell is going to rupture, and here we'll see if this elementary body is coming out and infecting other cells. That's how it spreads. So just a short recap, because we'll discuss this particular diagram when we'll be discussing chlamydial discharges. But very shortly, we're going to discuss the life cycle of chlamydial microorganism. So here we have the elementary bodies. It attaches to a susceptible cell. The cell engulfs like macrophage. Let's say in the LGV, it's a macrophage which is going to engulf the cells. So they will engulf the elementary body. Then elementary body inside the cell, inside the phagosome. So when this will be engulfed, this will become a phagosome. So inside the phagosome, the elementary body will gradually transform into a reticulate body. Okay, when that reticulate body happens, there will be binary fission of those reticulate bodies. RB is reticulate body. Now reticulate body is going to divide multiple times, and within the first 24 hours, the division has started. After that, the organism enters a growth phase which can be highly variable. When the growth phase happens, there will be multiple reticulate bodies. So these are all multiple reticulate bodies. So after growth phase, the single cell is infected by multiple reticulate bodies. After that, this is 24 hours. Now after 48 hours, there will be you could say a transformation of reticulate body to the elementary bodies. Okay, and this will continue till 3 days. So this is day 1, this is day 2, this is day 3. So over the next uh, first day, EB will become RB and start dividing. Over the next second day, RB will continue to divide, and from second to third day, there will be majority of EB more than RB. So third day will be EB more than RB, while before that it will be RB more than EB. And gradually the shift towards EB happens, and subsequently at the end of third day, you can see the cell is significantly infected by the elementary bodies majorly, and this elementary bodies, when the cell will rupture, it will release and they will continue to infect other cells. Okay, so that is a very short life cycle of chlamydia. Let's move forward. Now, one more thing that I would like to say, that this reticulate body can persist inside the cell where the growth, the speed of growth is significantly reduced and the speed of division is significantly reduced, and it can persist for years altogether inside the cell. It might not form an ulcer suddenly, or you could say it might not form an ulcer uh, just after infection, but it can persist for multiple years after that because of a reduced growth and division phase inside the susceptible cell or macrophages. Let's discuss a short note about structure of these elementary bodies and the reticulate bodies. Elementary body cell wall has two antigens. One is the common heat stable antigen, which we test in the complement fixing test when we test for chlamydia or we test for LGV. One of the important tests is complement fixing test, and this is the antigen that we test for. The other is type specific heat labile antigen, which we use to differentiate between biovars. Now, this heat labile antigen have been labeled as an endotoxin-like factor, and because of this endotoxin-like factor, you have constitutional symptoms like fever, malaise, okay, myopathies, general feeling of non-well-being. So that happens because of this type-specific heat labile antigen. After the cell wall, you have the trilaminar outer membrane, and this trilaminar outer membrane has outer membrane protein. And this outer membrane protein is very rich in disulfide linkages, and because of this increased disulfide linkages, the EB, the elementary bodies, are able to attach to the cell and infect it. Okay, then we come to inner membrane and the periplasmic space. And as we say that the major outer membrane protein is responsible for the integrity and attachment of elementary bodies to the susceptible cell, other ligands are heat shock protein 70 and glycosaminoglycans. Now these are important, maybe viva question, or maybe it can be asked in a quiz, that what are the attachment ligands for LGV. It is major outer membrane protein and HSP 70 and also glycosaminoglycans. The lipopolysaccharide is also responsible for infectivity. Now, for stains and culture, elementary bodies stains as a gram-negative body, and the stains used are Giemsa, Castaneda, Machiavello, Geminis. Even in H&E, where it can stain faint blue, or Warden's starry silver stain, in which it stains black. The most common stain that we can easily use, and it is present with us, is Giemsa. Okay. The reticulate body, however, is basophilic and stains well with Lugol's iodine because it is rich in glycogen. Now remember that the elementary body has significant disulfide linkages. We saw that in the last slide. When elementary body becomes a reticulate body, the sulfide linkages are decreased. And when reticulate body eventually transforms into an elementary body, the disulfide linkages are increased. Okay, and that is why when you are going from an elementary body to a reticulate body, cysteine is important. Remember that cysteine is a sulfur-containing amino acid. It has disulfide linkages in its structure. So, I think let me just recorrect myself. Yeah. So reticulate body has less sulfide linkages. Elementary body has more sulfide linkages, and that is why you need cysteine. Cysteine has disulfide linkages in the structure, and when reticulate body acquires these disulfide linkages, it becomes elementary bodies, and this process can be inhibited by cyclic AMP. Okay. Now, since Chlamydia trachomatis is an intracellular organism. It cannot be grown significantly well on artificial media. You need to add living matter to the growth media. That is why the cultures are seen mostly on human cell lines or animal cell lines. For example, chick embryo yolk sac is a media used to grow chlamydia. Other media include HeLa lines, McCoy cell line, or the endothelial cell culture line. So these are important media which are required for the growth of chlamydia. Otherwise, chlamydia is very difficult to grow on regular agars and different medias. We need cell lines to grow chlamydia. So we have discussed about the agent. Now we'll discuss what actually happens when the agent goes inside the body. So it's a lymphotropic organism. Okay, that means it majorly goes towards the lymph nodes, and when it reaches the lymphatics and lymph nodes, it causes thrombolymphangitis, which is blockage and inflammation of lymphatics, and perilymphangitis, which is inflammation of surrounding structures around the lymphatics. Okay, so what actually happens? The organism enters the body through an abraded skin or mucous membrane. Okay, the skin is broken, the organism enters. It gets concentrated in the draining lymph node where it causes lymphangitis and lymphadenitis. Lymphadenitis is inflammation of lymph nodes. That's why it's lymphadenopathy. Okay. It stimulates endothelial cell proliferation in the lymphatic vessels and lymph channels and the lymph nodes, and then it causes gradual increase and swelling of lymph nodes. When the swelling is significant enough so that the center part is not able to get the nutrition, you have necrosis. Okay, so if I want to describe it as it is, that you have one good lymph node, the organism infects the lymph node and causes significant inflammation. And because of that, the lymph node gradually increases in size and the center part undergoes necrosis. Okay, so center part undergoes necrosis. And because of that, you have lymphadenopathy with necrosis. And what happens in necrosis? The cells are going to die. And what are the major inflammatory cells that are going to reach first at the site of inflammation? These are neutrophils. So you have significant neutrophilic chemotaxis. Okay. So let's revise with me. It enters through abraded mucosa, goes into lymphatics, causes inflammation and causes inflammation of surrounding structure, goes to lymph node, increases the size, causes significant inflammation, causes necrosis. When necrosis happens, you have neutrophils coming to the area. So when neutrophils come, they form these kind of stellate abscesses or triangular abscesses. So what exactly do we mean by stellate? So either it could look like this, I'm talking about HNE and histopathology and biopsy. So either it can look like this kind of abscesses or quadrangular like abscesses, like a four-pronged star. So this is known as stellate abscess, and this is known as triangular abscess. Okay, surrounded by epithelial cells, macrophages, and giant cells. So this kind of happens. We know we need giant cells because the disease is going to form granuloma. Remember the name. Everything is in the name. Lymphogranuloma Venereum. Okay. Now these abscesses, when they are increased in number and size, they may become multiloculated and eventually rupture to form fistula and sinus, which will undergo fibrosis, lymphedema, induration, and then elephantiasis or the deformities that we associate with LGV. Okay. Now, this kind of necrosis and ulceration and deformities is known causes estheomin. Now, what do we mean by estheomin? Estheomin literally means eating away. Okay, so it means eating away. So when we look at the morphology of the genitalia, which is infected by the LGV causing the deformities, it looks like this significant ulcerative damage, significant destruction of tissues with swelling, with fibrosis. It looks like it eats away the normal human tissue. That is why the name estheomin was given, and it's mostly seen in females because the first stage is missed and they miss the treatment. If it involves the rectal mucosa, it causes strictures, ulceration, which is termed as anorectal syndrome. We'll study that further. If it goes inside the blood, it might cause systemic infection. And because of the cell-mediated hypersensitivity to chlamydial antigens, there is increased inflammatory damage to the areas. If the damage is not that severe and the cell goes into the latent phase where the cell growth and division cycle, the speed is not that much, it might remain there for multiple years, causing latency of LGV infection. That is why even after treatment, you need to follow up the patient for the next 6 months to see if there's any recurrence of the infection. That is why LGV is very difficult to treat, that because it may recur, and there are no good studies which will show you that these kind of antibiotic or these duration of antibiotics work well for LGV, making it a very difficult disease to actually treat. Okay, so we have discussed about the agent and how it actually infects the tissue, how it goes about. And because of the different stages of infection, we have divided LGV into majorly three parts. We have primary, secondary, and tertiary stage. Okay, so first I will just talk about the general things, which is the incubation period is 7 to 12 days. Okay, but it can be as long as 6 months to 12 months. So if the books mention 7 to 12 days, if you have to say one thing, it is 7 to 12 days in Vivas or in exams. Okay, so you make sure that you know about that incubation period is 7 to 10 days. That means after infection you might have ulcer within 1 or 2 weeks. Okay, it starts as a transient papule, where transient papule, eventually becoming pustule, then ulcer, and then become very much nodular ulceration. And then it can also present as non-specific urethritis in 5% of patients. Okay, in 5% of patients, it can present as a non-specific urethritis. You are not able to find any other symptoms. 5% of male patients, while in 15% of female patients, it can present as vaginal discharge. So that can happen. Okay. Benignitis, Granulocystitis, that is inflammation of the penile shaft and the glands. It is seen roughly in about 2% of males. Okay, and the most common site is the coronal sulcus. Let me just write it here. Coronal sulcus. But other sites like frenulum, prepuce, penile shaft, urethra, glands, these all can be involved wherever there is eroded mucosa. Okay, but the most common site is the coronal sulcus, which is the site of the most trauma. Okay, in females, it could be analogous to uh, labia, vaginal area, perineum, fourchette, cervix, where it might remain hidden, vulva. Okay, and in the MSM population, it can be seen majorly involving the rectal mucosa. Okay, so complications seen at primary stage is phimosis, labial edema, and in fact infertility if the inflammation is too much that the urethral structure gets blocked or the ducts get blocked. Another important thing to know about is known as bubonolus. What do we mean by bubonolus? It is seen in the primary stage of LGV. So what happens is that remember that LGV is a lymphotropic organism. Okay, it causes the inflammation of lymphatics, and the lymphatics become thickened and cord-like. Okay, so cord-like lymphangitis of the dorsal of the penis causes sclerosing lymphangitis, and it presents as a solitary, large, tender lymphoid nodule. The nodule may eventually burst, forming fistula and sinuses, and that nodule, that large nodule, is known as bubonolus. Okay, we're clear about it. So this term is important to remember, bubonolus. Okay, let's learn about the secondary stage now. Now, LGV can move from first to second stage in 2 to 6 weeks. In 2 to 6 weeks, but it can be as long as 4 to 6 months. Okay. Now, what happens is secondary stage is known as inguinal syndrome. Okay, inguinal syndrome. Now it's going to involve the inguinal area, the surrounding area. So on first stage, it was majorly involving the mucosa and the draining lymphatics. Now it is involving the lymphatics and the surrounding area. So it causes severe proctitis, bubo formation, which we see in the secondary stage now, inguinal multilocular abscesses, and very important groove sign of green blood. Okay. groove sign of green blood. Now understand that bubo is nothing but an inflamed lymph node which is so much inflamed that it has underwent necrosis. Okay, at the time of presentation, if it is fluctuant, that means the necrosis is significant. Otherwise, it can be presenting as a non-fluctuant swelling also. It is still known as bubo. Okay, around 75% or you could say 3/4 of the cases, the bubo might resolve on its own. But in the next 25, it may rupture to form draining fistula and sinuses. Okay, now one thing very important to understand is the groove sign of green blood. So that is a very good question. So what actually happens is, let me just erase this and quickly explain you what do we mean by the groove sign of green blood. So imagine this as the inguinal ligament. Okay, and you have two group of lymph nodes. One is the femoral lymph nodes, which are somewhat here, and then you have the inguinal lymph nodes above, or the superficial inguinal group of lymph nodes, which they are somewhat horizontally located. Okay, so this is superficial inguinal and this is femoral group of lymph nodes. Now what happens is, because of lymphadenopathy and the area involved, the inguinal area involved, this will become swollen. And when this becomes swollen and undergo necrosis, you will see a swelling here and a swelling here. So on physical examination, it will look like that you have a swelling, the inguinal crease and another swelling. And because of swelling, the skin is raised here, it is raised here, but because of the inguinal crease, it is depressed. Okay, because they are two different group of lymph nodes. So it forms a groove in between these swellings. And this groove is known as the groove sign of green blood. Okay, so that is important and concept to understand that it's a very important question also, that what all lymph nodes are involved in the groove sign of green blood, and it is superficial inguinal lymph nodes and the femoral group of lymph nodes, and it is caused by the indentation caused by the inguinal ligament or the Poppert ligament. Okay, now the lymphadenopathy occurs in 1/3 of the cases. It will occur as unilateral. Now remember, in chancroid it is bilateral. It is unilateral in 2/3 of cases. Okay, and in significant inflammation might occur, causing matting of lymph nodes, and that can present as a stuck lymph nodes or a very big swelling. So that can easily be the presenting complaint of the patient. They might bypass the first stage and present directly in the second stage. The complications include sinus tracts, frozen pelvis, infertility again, systemic arthritis. Now you may understand, as we are going from first stage to second stage, the number of complications and the severity of complications are increasing. We have perihepatitis, meningoencephalitis, so all sorts of complications. The ulceration is decreasing, but the fibrosis is increasing as we move from first stage to next stage and all. Okay. In females, lymphadenopathy is seen in about 20 to 30% of cases. Majorly lymph nodes, or the most common lymph nodes which are involved, are the deep iliac and the perirectal lymph nodes. So this becomes a very important question, that in females it is the deep iliac or the perirectal lymph nodes, because these are the deeper organs are involved first. So all the lymph nodes which are draining the affected area are the lymph nodes that are going to get affected by LGV. It majorly presents as lower abdominal pain or back pain. Okay, and if pelvic lymphadenopathy is severe, it can cause cystitis, urinary retention, and because of perilymphangitis and adhesions, it is known as frozen pelvis. Now, what actually happens is that because of the lymphatic fibrosis and the perilymphatic fibrosis, the internal organs in the pelvis are adhered to one another. They get stuck together because of inflammation fibrosis, and that is a term which is known as frozen pelvis. So we just need to understand that this term is used in LGV in females. Trust me, the clinical features are difficult to understand and remember, and the treatment is just to remember, the treatment is easier. Okay. In the MSM population, proctitis is the presenting complaint because of rectal exposure, but majority of them, they can be asymptomatic also. If the rectum is involved, you see as perianal ulcers, anal cramps, tenesmus, pain. bloody discharge, or constipation. Most of the MSM population might also have an HIV co-infection, and in the immunosuppressive stage of HIV co-infection, the disease might be asymptomatic. And we do have to check for other STIs in MSM population. Now, in the tertiary stage, secondary stage was called as inguinal stage or the inguinal syndrome. Tertiary stage is known as genito-anorectal syndrome or the genital syndrome or anorectal syndrome or proctitis or proctocolitis. These are all names. Just remember genito-anorectal syndrome. As I have told you earlier, that now the complications are a lot. Okay, so as we are moving from stage to stage, the complications are increasing because the inflammation and fibrosis is increasing. Okay, the secondary stage is characterized by elephantiasis or the significant swelling and fibrosis of the genital area. Okay, it's roughly seen in about 25%, but this is, I think, overestimation. This was done when the LGB was very endemic in the world. Now the significance or the prevalence has somewhat decreased because the ulcer stage or the because of good antibiotics, and in India people take antibiotics for all sorts of things. So maybe the incidence of tertiary stage or the migration of patient from secondary to tertiary has decreased over the years, but it is still significant. Okay. Elephantiasis can take about 1 to 20 years to develop. Okay, it can be slowly developing, majorly because the disease might be in its latent phase or latency phase. Okay. Mhm. Apart from that, we will just discuss each and every syndrome very quickly and somewhat in detail. We must focus more on the complications, which include the genital elephantiasis or ramrod or saxophone penis. Now, this is very important because short notes usually come on this, like a short note on saxophone penis or ramrod penis or estheomy. So this can happen, and in that cases, you have to mention a bit about LGV, the age and primary stage, secondary stage, and then detail about tertiary stage and complications of LGV. So all the stenosis, fistula, abscesses, involvement of the internal organs, perirectal organs, pelvic organs, lower abdominal organs, all comes into the tertiary stage now. Now here we can see the ramrod penis or the saxophone penis. It is bent, disfigured. Okay, the reason it is called as saxophone because if you remember, saxophone looks like this. So that's why, because of increased curvature, fibrosis, swelling, it is known as saxophone penis. I'll see if I can add a picture of saxophone here. Maybe I'll add it somewhere around here in editing so that we can know what actually saxophone looks like. Okay, so this is a picture which I've taken from book. I've changed the color because YouTube doesn't allow. I hope I will get away with this. And this is estheomen, and because of estheomen there's significant growth, granulation tissue, fibrosis, ulcerative sclerosis, everything and all sorts of things leading to genital mutilation and disfigurement. And this disfigurement is very significant and harming to the patient. And most of the time it's commonly seen in females because that is how they present to us, because the primary stage is missed. After the tertiary stage, you have individual syndromes which are known as Uro-Genito-Perineal syndrome and other ocular and extra-genital manifestation. We'll discuss them in details now. Okay. So quickly we'll discuss the Uro-Genital syndromes. I know that the video is going to be very long, but trust me, this is the only video we need to know about LGV. I've covered at least 4 textbooks and 6 articles for this video. So anything you need to know about LGV, everything is here. Okay. Now, what happens is that because of chronic inflammation, you have hyperplastic ulcerative changes in the anorectal mucosa. We're talking about the Uro-Genital syndrome. Okay. And because of the intense inflammation and chronic inflammation of the rectal mucosa involving the lower 8 to 10 centimeter of the anorectal region, which is below the peritoneal reflection, So if you look at the cross-sectional vertical section of the human body, this is the rectum, and the peritoneum. Let me just change the color. The peritoneum is reflected here. So roughly it involves the lower 8 to 10 centimeter around about this area, the mucosa of this area. Okay. And there is diffuse edema and diffuse inflammation of the mucosa causing intense pruritus and rectal discharge. So if you see a patient of rectal discharge and if the patient happens to be MSM, you have to be very careful. You might be dealing with tertiary stage or Uro-Genital syndrome of LGV. In per rectal examination, you will see the pebbled appearance of mucosa. This is a good viva question or a quiz question. And that is because of enlarged and infected the edema of the rectal mucosa on rectal examination. The mucosa is swollen, so it will feel like a pebbled appearance, like you see in pathways where the stones have been laid. So pebbled appearance of mucosa. Okay, the mucosa is hyperemic, that means very red, filled with blood, friable, it bleeds on manipulation because it is inflamed and damaged. And on proctoscopy, you might see superficial ulcers which are healing with granulation tissues. So this is the Uro-Genital syndrome or the rectal proctitis syndrome seen in MSM majorly, but other areas also. Because of chronic proctocolitis or the chronic inflammation of the rectal mucosa and the non-caseous granulomas, the infection of crypt abscesses happen. Now, what it is, if you remember your anatomy of the anal canal and the rectum, there are anal crypts around the anorectal junction, and because the crypts get infected, they may become swollen and easily painful and damaging. Okay, after about 3 to 6 months, significant fibrosis occurs, causing contractures, and because of contractures, this area gets stenosed. It decreases in the diameter. Okay, so because of this, it will become like this. So you will have stenosis and strictures at this junction. Now, this stenosis has been divided into three parts. I'm just mentioning it quickly so that you may know. The another one, in which you have a ring as a stenosis, it is the most common, seen in 65% of cases, and might be responsible for causing chronic constipation. And the stool that comes out in pencil shape. Okay. Why pencil shape? Because the orifice is now small. So the anal canal, which was initially this much long, is now stenosed. It decreased in diameter to just this, and that is where the stool comes out like a pencil stool. Okay. And the third is tubular, where the entire ball length is stenosed. So this, if let me just draw it again. So this is the, you could say, anal and the rectal area, and the entire bowel length becomes a tube. So this is the tubular one, and a funnel is when it only the lower part is stenosed and the upper part is dilated because of the stenosis, and it becomes like a funnel. So this is the funnel type. Prolonged inflammation can even lead to rectal adenocarcinoma, which was reported in 2 to 5% of cases. So it becomes a very important complication of chronic Uro-Genital syndrome. Now, what are lymphoroids? Lymphoroids are nothing but what happens is when lymphatics are significantly inflamed, and because of the swelling, they swell up and they are felt as bulges inside the rectal mucosa on rectal examination. And this bulging, so if it is filled with blood, it is hemorrhoids. If it is filled with lymph because of swollen lymphatics, it is lymphoroids. If the inflammation is significantly involving the other organs also, it becomes Uro-Genital-Perineal syndrome because now it involves the perineum. It happens because of long-standing inflammation. In women, you have the involvement of the urethra, ureter, urinary bladder, and all sorts of things. In males, it is majorly seen as stenosis of urethrum. It can involve the lower pelvical organs like anal, rectal, all sorts of organs can be involved in urogenital perineal syndrome. But the involvement of urinary meatus or the urethral meatus leading to urinary retention and stenosis is the hallmark of perineal involvement. And when perineum is involved, which is the outer area, vulva, vaginal area, genital area, and all that, it becomes Uro-Genito-Perineal syndrome. That means all the manifestations seen in the previous two slides plus the involvement of perineum, you have the Uro-Genital-Perineal syndrome. In ocular, we will not study much. It is majorly caused by L2, by auto-inoculation, and the draining lymph nodes are involved. So you have the cervical or the facial lymph nodes, and hypersensitivity reaction can cause conjunctivitis. These are not very important for us, but we should know that this kind of complication can occur in LGV. Extra-genital manifestations are rarer, but it can be seen in tonsillitis, oral lesions. With the oral exposure, this can be involved. And the draining lymph nodes, like the cervical or submaxillary lymph nodes, they are the lymph nodes which are involved and they become more swollen. Okay. Pericarditis has been described, chronic cholecystitis has been described, psoas abscess if it is involving the muscles and the internal organs, the pelvic organs. Reactive arthritis because of proctitis due to C. trachomatis L2B Biovar has been reported in few case reports, one or two. So that's one another significant and distressing complication of LGV. Now, HIV co-infection. Whenever you're talking about HIV co-infection in STI, you have to divide it into two parts. What does the STI do for HIV and what does HIV do for STI? What happens is when the patient has LGV, the co-infection is seen with HIV because mostly the population involved is MSM and they may have multiple STIs. Additionally, co-infection with Hep C has been seen in about 18% of cases. This being an ulcerative disease, in the primary stage of LGV, you have the ulcer. Okay. In the secondary stage, because of increased swelling, increased granulation tissue damage, there can still be ulcers, and because of the ulcer, there is significant increase in the transmission of HIV. So LGV can increase the transmission of HIV. Now, what does HIV do for LGV? The clinical presentation is usually similar. However, there can be multiple ulcers, multiple lesions, multiple abscesses, and the disease might also reactivate. Remember what is happening. The Chlamydia trachomatis is residing inside the macrophage and dividing. Okay. If the macrophage is not able to check that division and destroy the organism and remain there, persist there, it will lead to latency. And whenever the disease is in latent stage, it can always reactivate. So reactivation is an complication when HIV and LGV infection is seen together. The treatment remains same, but the patient might require prolonged treatment. Differentials. So in STI, whenever you're discussing about differentials, you have to divide into two parts. STI diseases other than the LGV or non-STI cases other than LGV. So in primary stage, it can be herpes, syphilis, or chancroid, and non-STI being traumatic ulcers. While in non-STI differentials of the inguinal syndrome, we can say as plague, Hodgkin disease, inguinal hernia, psoas abscess. So I'm just, I'll remove all the markings so that you can take a screenshot of this. But if you look at logically and if you have paid attention to this video when we were discussing the pathology of LGV, you can easily think about multiple differentials of all these stages. Okay, without much further ado, we'll move forward. Diagnosis. We'll quickly go through it because most of the time the diagnosis is you have to make it clinically. Good tests are not available everywhere. The point of care test or the PCR test are usually available in institutions. So we have to be you have to be working in a very high level institute, or you must have access to these kind of PCTs test so that you can diagnose it using those tests. And since chlamydia cannot be grown on artificial media, you have to use yolk sac or HeLa cell lines. You might not be able to grow this organism. So most of the time, what you can do is take a swab from the ulcer and stain it with GMSA. You might be able to catch macrophages which are infected with Chlamydia trachomatis. So that can happen. Okay. Now, the gold standard for LGV diagnosis is Biovars specific bacterial DNA. That means you take a swab either from rectum or genital ulcers or bubo aspirate. Now, remember, in bubo aspirate, which is caused in donovanosis of chlamydia, you might not be able to isolate the organism. However, you cannot isolate organism here also, but the chances might increase because it is a lymphotropic organism. It stays inside lymph nodes. Okay. So the gold standard is that you isolate the organism and you do biovar analysis for the specific bacterial DNA, and you are able to isolate and recognize the organism as Chlamydia trachomatis L2. Okay. Now there are pan-Chlamydia trachomatis NAT available. NAT is nucleic acid amplification test, which is somewhat of a PCR point of care test. Okay, so first you do a pan NAT so that you know that the organism you're dealing with is Chlamydia trachomatis, and then you have a LGV Biovar specific DNA NAT in which you find out what Biovar you are dealing with. You also have real-time PCR for all trachomatis variants. You have RT quadriplex PCR, which can differentiate between LGV and non-LGV causing biovars. This is important because you need to differentiate between ocular type, whether that is because of autoinoculation manifestation or any other biovars which is causing the disease. Now, FAIR test is intradermal test based on delayed hypersensitivity. It is an old obsolete test, difficult to do. We are not going to do it. In order to collect the specimen, you have to use rayon or polyethylene fibers because they are found to be better than cotton and calcium alginate. So remember, in chancroid and other ulcerative diseases, cotton swab was good enough. But in LGV, it's better to take this kind of rayon or PET fibers so that the organism, which is itself difficult to grow, you don't have any other problems in growing it. The best sample to be taken is biopsies, however, even for culture growth. Even if you want to culture the organism, the sample taken is not, the swab is not that good. Take a biopsy sample, you can get a huge yield out of it. Now, cytobrush collects more material and it increases the sensitivity of the test. Now, here, this is the cytobrush. So it has all of these fibers coiled around a metallic wire. So what happens is it disturbs the mucosa and a lot of infected cells are taken out. Remember that chlamydia is an intracellular organism and it is residing inside the cell. So if you want to take something, if you want to take the sample, you have to take a lot of epidermal cells also. The other instrument is Ayer's spatula. So this can also be used so that you erode the mucosa and take the sample. Erode the mucosa and take the sample. Okay. So if you are taking samples from bugo, you have to aspirate the pus if it is fluctuant. If it is tight and not fluctuant, you inject saline and then aspirate and send it for culture. Now remember, culture has to be very quick, ideally less than 4 hours. Okay. In fact, if you are using tissue cell line, it should reach the cell line in less than 2 hours for the organism to grow. Otherwise, it won't survive. Okay. So you can take samples from bugo. You can take samples from rectum where you have to go as deep as 3 centimeter into the anal canal and rotate for 10 seconds. We are talking about cytobrush, which you rotate so that the mucosal cells are eroded and we catch them. In urethra, you have to go as deep as 3 to 4 centimeter into the urethra and rotate for 5 to 10 seconds. If it's cervix, you have to clean the exocervix so that the contamination is decreased. Then you insert the swab 2 centimeter into the cervical canal and rotate for 10 seconds. Okay, 2 centimeter in the cervical canal. If it is eye, you have to evert the eyelid and then run the swab over the conjunctival mucosa. And in throat, you take it from the tonsillar crypts and the posterior pharynx. If you're thinking about oral LGV, or in fact for any other STI, take it from the tonsillar crypts and the posterior pharynx. Other tests, we'll just name those tests. It's just important for academic point of view. You have antigen detection, antibody detection, and immunotyping of the isolate. To detect the antigens, you use enzyme immunoassay and the point of care test. Point of care test gives you result within 30 minutes, but they cannot discriminate between LGV and non-LGV biovars. They are not that much available in India also, and you have access to them only in higher institute studies. Antibodies to the antigens are detected. We may use complement fixation test, which is the most widely used test, which may remain positive, which becomes positive after 1 to 3 weeks of infection. So nonetheless, you're going to miss the primary stage. Okay. Write down the answer to this question in the comment section. Okay, the question is what antibody to what antigen are we testing in complement fixation test? The answer has been given in prior slides. Okay. The microimmunofluorescence test is the most accurate, but it is very complex and laborious. So most common is CFT, complement fixation test. Most accurate is microimmunofluorescence test, but it is very difficult to do. Other tests include a single type chlamydial fluorescent test, radioisotype precipitation test, okay, neutralizing antibody test, immunoproximity test. These are all names. If you just remember them, you can write them in exams. Maybe the examiner is happy. They are usually not. Okay, so immunotyping of isolate is used only for research. We need not know. If we want to know, just know the name. Just remember that whenever you're talking about diagnosis of STI, you have to go from isolation of organisms, start from the swab, start from the normal routine cultures, and then you start growth on artificial media if present, then growth on yolk sac, cell lines, then you go for antigen detection, then you go for antibody detection. You have to answer the diagnosis of STI under these headings always. You won't forget anything there. Treatment. Now, this is the easiest part to remember. Difficult to treat clinically, but easiest to remember. In the in the acute stage, our motive is to eradicate the pathogen. You have to make sure the pathogen dies. In the chronic stage, where deformities have set in, you have to treat the deformities mostly by surgical methods. Okay. So we'll discuss the CDC, NACO, and not WHO per se, but CDC and NACO guidelines. CDC guidelines says that doxycycline is the preferred regimen. Okay, it is the recommended regimen. Doxycycline 100 milligram twice a day. Okay, 100 milligram twice a day for 3 weeks orally. Okay. If this doxycycline is not used or for any other reason you cannot give it, the next are the azithromycin and erythromycin as alternative regimen. So you have azithromycin 1 gram once a day, okay, 1 gram OD for 3 weeks, or erythromycin 500 milligram 4 times a day for 3 weeks, okay. So repeat with me. First, the recommended regimen is doxycycline 100 BD for 3 weeks. Alternative regimen is azithro 1 gram OD for 3 weeks, or erythromycin QID for 3 weeks, 500 milligram. Clear? Now, partners who are exposed to your patient within the last 60 days. CDC mentioned 60 days. I have seen articles and books mention 6 months. Okay, but you have to track them down and see if they are also infected and treat them. Treatment is doxycycline 100 milligram BD for 1 week, and this is known as presumptive treatment. Okay, so what happens is, let's say you have a patient of LGV, diagnosed LGV, you are treating it, and there has been exposure in the last 20 days. So you call the patient's partner and give them doxycycline 100 milligram BD for a week. You examine the partner first. If the partner has any lesion, you treat as a case of LGV for doxycycline 3 weeks. If there are no lesions, no manifestation, you give them doxy BD for a week. Clear? In NACO, the kit that we use is the kit 7 or the black kit. Okay, the kit 7 or the black kit is for inguinal bubo or for any swelling in the inguinal region which may be painful. Any history preceding with a history of genital ulcer or a discharge, and with systemic symptoms by malaise or fever. So this is the kit 7, the black kit of NACO, and it has doxycycline 100 milligram twice a day for 21 days, which is the regimen covering LGV. Additionally, azithromycin 1 gram stat dose is given, okay, which is to cover chancroid. Okay, so black kit is used. Follow up the patient, you need to have a test of cure. Now, test of cure is that after 4 weeks of treatment, you repeat all the tests which were initially positive for LGV. Their test should become negative. When it is negative, you say that you have cured the infection. Okay, so that is known as test of cure. For LGV, it is important to do because there is persistence of organism, there can be latency of organism, and the treatment might be delayed if the patient is suffering from retropositive also. Ensure that ulceration, or if you're treating an ulcer, that is removed. If you're treating discharge, that is improved. The healing is significant. There is no co-infection with HIV or any problem with immunodeficiency. Look at the reports. Usually we get Hep B, Hep C, VDRL, TPHA done. So look at those reports. Answer any patient's concern that they might have on follow-up visits. You manage the partners for in the preceding 60 days. You manage the partners. And then you monitor for recurrence for the next 6 month post treatment. So you have given the treatment here. Let's say patient presents to you, you have given the treatment here for the next 6 months. Keep the patient under your follow up so that you can see if there's any recurrence of infection. Okay. In pregnancy, you can use erythromycin base. Azithromycin doxy causes discoloration of teeth in units, but keep it as a last resort. Best drug to use is erythromycin base. Remember, erythromycin base, not mesylate. Erythromycin mesylate causes hepatotoxicity. Erythromycin base, 500 milligram QID for 3 weeks is good enough. Other than that, azithromycin 1 gram for 3 weeks is good enough daily. Okay, with that, we have finished this long video on LGV. LGV is long because it causes a lot of complications. It causes a lot of disfigurement of the genitalia. So we need to know about how the pathology actually sets in, causing all sorts of deformities. There are reading recommendations. If you want to know in detail about the Amsterdam variant, you can look at this article. I'll put the links in description. The CDC and NACO guidelines are given, and otherwise apart from that, this video has all the information you will require for exam point of view and also for treating your patients who are suffering from LGV. Okay, uh, with that I'll finish this presentation. It has been long. I think it has crossed 1 hour, so I will not take much of your time. Enjoy your weekend. Any comments, suggestions, anything else can easily be emailed to me on my email ID, or you can write in the comment section. So adios, bye bye, and enjoy your weekend. Ta-da.